Okay. Technique and technology, handling challenging cases, Vaishali. We can't hear, you're muted.
Sorry. So thank you, everyone. And I'm very happy to be listening to all these talks. But I think what I will be talking about in the next few minutes is basically all these, the science that we know, all the patient counseling, all our smartness. It doesn't translate into a good patient experience unless you are good at handling not only the routine cataracts, but also if something goes wrong, and which it will go wrong many, many times. That's, I think, where we need to step up so that we can keep delivering these outcomes time after time. And like Shail mentioned, we, all of us at Raghudeep Eye Hospital, do receive occasional research grant from Alcon Laboratories. Let's start with this case. A 30 young male obviously has glare at night while driving because he has a cataract and bilateral posterior polar cataracts. So before we start the discussion of whether a posterior polar cataract first eye young patient, would you counsel about a presbyopia correcting IOL? I think yes, there is a valid point that even if you could do it in the first eye, you could have a PCR in the second eye, maybe you can't put it. But with due counseling, I think especially these posterior polar, because they are mostly young patients, they should be given this option, provided during surgery you can manage to save their posterior capsules and do a good job. So here we find the technique of femto delineation, which is basically creating these cylindrical cylinders with the femtosecond laser, very, very useful. Also, you get a very good sized and centric rexis. And look at the incision. There was a lot of criticism a few years back about femtosecond incisions, but I don't think that's true, at least with the LensX platform that we are used to. So my point again, technique and technology. Not that you could not do it without a femtosecond laser, but as we have published way back in 2014, our PCR rates have dropped to less than 4% with femtosecond compared to at least 8%, which has been reported with every other manual technique. So just to give a brief, these cylinders give us multiple layers of cushions to emulsify the lens so that there is always a thick mechanical protection which shields the posterior capsule while you are performing the surgery. And let's see how this is going on. Now you would sequentially, one by one, you remove these cylinders. Here again, using the technology that you have to your advantage. So look at the IOP of 30. That means a bottle height of about 45, 50. In your machine, you use the lowest comfortable. I wouldn't say go extremely low, but use a low flow rate. You don't need any energy because at least this lens is absolutely soft. And the flow rate is only 20 cc per minute. So again, combining technique and technology. The other thing I also find very useful is don't keep moving your phaco probe in and out and going this way, that way, because that stresses the incision and there is leakage. And especially in these eyes, you don't want too much fluctuations in the anterior chamber, even if you are operating with the best technology. Now, what is being done here is that the epinucleus or the last shell is being stripped off in almost 180 degrees, as much as can be managed from that side of the incision, and then inject dispersive viscoelastic and come out. So I think what we saw in this is that there are very well-defined and very sharply cut zones which can be sequentially removed. And unlike a manual hydrodelineation, either a conventional or an inside-out delineation, you are left behind with this epinucleus cushion, which is not only very thick, but it's uniform and it has very sharp edges because it's a laser cut. So it's much easy to strip off. Now, once you have done that, there is now an opening. That means communication between the anterior and posterior chambers. And now, once you come out of the eye, injecting viscoelastic, making the space, then you could even perform small aliquots of hydrodissection to free up that epinucleus and cortex, which is sometimes very adherent. Now, bimanual IA is being used here, and I think, at least in these cases, again, talking of a blend of technique and technology, I would go with a bimanual IA, even if I'm not using it as a routine, because one, you don't use the main incision, two, you don't have to stress these incisions, and without causing any chamber fluctuations, you can easily access 360 degrees of this epinucleus plate. So now again, notice that the bottle height or the IOP is very low. That means you don't want too much inflation. These capsules are inherently weak, and let's say there is a small defect which you may not be able to notice at this point. You don't want too much infusion pressure hydrating the vitreous. And we can see here that using the good technology and skill, obviously, which cannot be undermined, the entire capsular bag is empty. And as is typically the case with a lot of these young patients, the posterior capsule will typically have some deposits or some plaque, as you can see here. Now, this is the thing I want to highlight here. Just keep a watch on this area as we play the video next. Is that, yeah, you may be the greatest surgeon, you may have the best technology, but sometimes there is, it might make sense to leave behind a little bit of the plaque and then laser it. And this example will probably show that. Just keep, while we are polishing, can you notice this posterior capsule rupture that happened? So a posterior polar cataract, even if you ended up with a clean bag, please don't take this lightly. We have had cases of rupture during polishing, during even stromal hydration. So they are weak capsules. So something that is, I know that this was planned for a so-called advanced technology IOL. So you want to have a crystal clear capsule, but instead you have ended up with an even clearer visual axis now. So now what do? Don't panic. That's where your technique and technology again will come in handy. Use a dispersive or a heavy cohesive viscoelastic or a viscoadaptive if you have access to. And then using microcapsular axis forceps, because it's a small central PCR, we don't want it to extend during IOL implantation. This is being converted into a posterior capsular axis. So the key here, it's not difficult to perform a PCCC. It's just keeping your nerves calm, that even though it's a young person, even though it may be a premium IOL, don't get nervous. Just do what you have to and grasp it a couple of times. The patient is under topical anesthesia, as you can see. But you can manage it if you keep your calm. It's not going to be very difficult. So from one side, this could be converted. Similarly, you pick up the other edge and convert it into a posterior capsular axis now. And you can see that we take all the time in the world. Don't hurry up in doing this. So as you can see now, this margin is very strong and continuous. So now I'm not worried about putting in any IOL in the bag. We are not talking about sulcus implantation. Again, inflate the bag here. And you implant in the bag very slowly. Now, one practical tip here, that sometimes if you use an IOL system which is very tight incision, you might want to enlarge the incision, at least internally a shade, because you don't want a forceful implantation. So that's where, again, this IOL, the Acrisoft IOL platform in general is very good. You can see how very controlled we can inject, and you can see here these rings and the toric marks. So this is a panoptic toric going in. And you can see how gently we are able to nudge it and put it into position without causing any stress. And it is now being dialed into position, being very, very gentle. But basically, we are not very worried because it's a very strong PCCC margin that we have created. And the lens can be dialed slowly and gently using bimanual maneuvers, not doing very, very large rotations at a time. And this is what we end up with. The viscoelastic is removed. Again, you see that the IOP settings, the flow rate are all modest. You don't want a very low setting also, but use modest settings because you don't want to disturb anything. And in fact, I think we have managed to clear the potential PCO also. So that was a little bit of the bright side. And this is what the patient looks like post-operatively, because it's important to see what actually happened. Intraoperatively, it's fine, but also post-operatively. So I think my message here, post-operatively, you can see that we need to monitor these patients for retina, especially, and the OCT looks very good. And the indirect ophthalmoscopy periodically is also very, very important. And this is 4 months down the line. So I think this case, there are several points. The first being how to manage a posterior polar cataract. But most importantly, 2 lessons that I learned. Number one, if you have a small posterior capsule opacity in these cases where you feel that you might have a weakening in the capsule, it might be more sensible to leave it behind, and pre-operatively always counsel these patients that you might need a YAG laser touch-up, as we say, in the post-operative period. But if you do end up for whatever reason with a PCR or a problem that you did not anticipate, please don't panic. Use your good common sense, and in most cases, we will be able to do it. Let's say you could not convert to a PCECC or it was a large PCR, then please don't be in any ego. Switch from a panoptic storic to a monofocal IOL and put it in the sulcus and capture it through the anterior capsular axis, because there is no way we can put in a single piece IOL, particularly an Acrisoft design, in the ciliary sulcus. Now we move on to this next case. And before I say, let me say that although we have handpicked these cases, I have one disclosure to make, that we don't create these complications in every toric or multifocal IOL. So that's just for the record. Here is a 65-year-old lady scheduled for a second eye toric. Now, whether it's a presbyopia toric or a toric or even a monofocal, it really doesn't matter. Second eye, we are always under more stress, because not only you want to hit the refractive target, but technically also you want to do a good job. This picture here, I just want to highlight that the rhexis is complete and it looks like a good normal soft cataract with a posterior subcapsular component. And surgery is being performed. The last bit of epinucleus is out, and notice that you can already see this split anterior capsule, which will become much more visible and flapping, as you can see. So we have a large, it's, I would say, almost about 2 clock hours plus of an anterior capsule split in this eye, where we were planning a toric lens. Now, again, like with any other complicated case, the most important thing, please don't panic and don't come out of the eye. Inject a viscoelastic, preferably dispersive viscoelastic. But if you don't have access offhand, just inject something before you come out. But don't overinflate, so that in this split, you don't want to extend it. So don't overinflate in the sense that don't make it too deep. And then come out of the eye. Then think about what you can do. Now, when performing IA, again, bimanual is a great help here. And the POPs technique, which I'll come to shortly, which Viraj showed us all and taught us all, I think is very handy. Don't strip, don't do radial pulling too much. Engage the cortex, pull it down, swipe it side to side, and then bring it to the center and aspirate. So raise your vacuum only in the 4th step once it is ready to be aspirated. Also, because you will have a lot of this heavy viscoelastic here, there might be an issue with clogging. So go into the area of the cortex and then actually engage and swipe it, so that you reduce the zonular stress in this bag, where you really don't know where the end point of the anterior capsule split is. And Dr. Rohit Om Prakash had several years back shown a very good video to detect whether your split is actually gone to the posterior capsule or not. So again, here this trick of mechanically feeding, sometimes you don't want too much surge. So you may not want your vacuum to hit the preset level of 300, 400. So you might want to work at around 200, 250. And you can always use the other hand to mechanically help the cortex in. But make sure that you remove all the cortex. You don't leave behind anything, because that will be a problem in the post-operative period if you did leave behind. So don't be scared. But on the other hand, be very mindful of what you are doing and keep a tab on your parameters, not excessively high vacuum, flow rate, bottle height, anything, but adequate obviously will be required. And this is what we end up with. Now, this is a printout of what the axis was designed to be, and to our fortune or misfortune, it is supposed to be almost in the same axis as the split is. So again, which IOL platform you use, and the Acrisoft allows us to perform a pretty controlled delivery. And now you can see that it's in the bag. Now, when you push it in, don't be very jerky, very gently glide it in. And now you can even rotate it, because you are sure that the capsular bag is now intact. But again, be gentle and slow 1 clock hour movements. Don't try to do it all in one go. So you can even put it in the same axis as the split. The only catch, yes, there would be, and it's a valid discussion, that there might be a tilt on the IOL, and with the asphericity and toricity in place, what would happen to the refractive or the visual outcome. But from our practical experience with this platform, because of its tackiness, and if you maintain the chamber well till the end of the surgery, typically it will not be so much of a clinical compromise. Yes, if you were to check the aberrations, maybe there will be some change, but practically speaking, it really doesn't bother. Always hydrate the incisions before you come back. And I practically also would like to inject a little bit of a myocol or carbachol or pilocarpine, whatever you have access to, because in the early postoperative period, you don't want that lens coming up or the chamber shallowing. So just narrow down the pupil just a shade. And this is what the patient looks like 2 months postoperatively, and unaided vision is 6 parts. So we end up with a good postoperative outcome. And just the last point before I come in, the POPS technique of cortex removal, which I find very useful, not in a PCR, in every case, but particularly where you have a zonular weakness or pseudo exfoliation. We'll quickly run through these animations. So first step is position your port, whether it's coaxial or bimanual, position it beyond the rexis and take a bite of the actual meat of the cortex, which you can see in the animation in the PIP as well. Then occlude, raise your vacuum, but not probably to your preset maximum. So occlude and only then start moving your probe. Once the occlusion is done, take this entire thing backwards, as you will see in the animation, because that will help to detach every part of the cortex and even the equatorial lens epithelial cells from this entire capsular bag fornix. And then swipe it. Once you pull it down, move it radially very generously so that you don't induce zonular stress and you can cleanly remove epithelial cells and cortex. So I think with that, I'll end my presentation.
Right.
So I had this interesting